And they're just like, oh my God. And they're talking about the money and the cost. And I just had a kid in here last week, and basically the discussion was on strike. They were on strike.
Yeah.
Now, if they go on strike from their supplements, it's not as disastrous as if they go on strike from a major antipsychotic that's holding them out of the hospital. Many of these meds, I am very frank about this, are chemical restraints. So your aggressive, self-inducing, abusive child to themselves and others does not end up in the hospital. Because if they start to self-harm or harm you, we do not have a choice. You and I, they have to go to be a safe place.
Welcome to Demystifying PANS and PANDAS, the podcast where we uncover the mysteries, breakthroughs, and hope behind these life-altering conditions. I'm Dr. Nancy O'Hara, a board-certified pediatrician, educator, and advocate with over 3 decades of experience helping children and families navigate the challenges of neurodevelopmental and neuropsychiatric conditions, especially PANS and PANDAS. These disorders can feel overwhelming, but here we'll break down the science, explore transformative treatments, and share stories of resilience and recovery. If you've ever wondered what's possible for your child or how to find answers, this is the place to start. Let's dive in. Hi, everybody. It's Dr. Nancy O'Hara again, and I am thrilled to welcome a colleague of mine, Peggy Chapman. Peggy is a clinical nurse specialist, board certified in child and adolescent psychiatric nursing, and she received her Bachelor of Science in Nursing at Creighton in 1976. In 1982, she graduated from Boston University with a Master of Science in Nursing and was certified as a clinical nurse specialist in 1983. And Peggy has worked in various roles in psychiatry in the Omaha and Boston areas, including as a head nurse of child and adolescent and adult psychiatric units, a therapist for children, adolescents, and adults, and as a psychopharmacology specialist for all ages since 1998. She's been active in supporting parents, co-leading the Asperger Association of New England Parent Support Group for 11 years, and being a medical advisor for New England PANS PANDAS Association for the last 11 years. She treated her first PANDAS patient in 1999 and opened the PANS Center, which we are all thrilled about, in June of 2025, which is dedicated to treating patients with PANS, training and educating other professionals about how to diagnose and treat PANS, and supporting research for PANS and PANDAS. So Peggy, thanks so much for joining me today.
Thank you so much for having me. I opened the PANS Center in 24. You said 25. We wouldn't be.
Oh, 24, right. 20. We're not even there yet.
All anticipating, right?
But that is an amazing thing that you did. And just tell people a little bit about the PANS Center just to get started.
So I was going to mention this, and Nancy asked me to conceptually talk about challenges. And one of the challenges is I thought I was going to retire about now. And I was frustrated because I couldn't figure out how to do that with all this information I had in my head about PANS and no one to give it to. And there was an earlier effort to try and do that didn't work. And my husband kindly sat me down and said, well, honey, you're not one step further than you used to be a year ago. So what now? And I go, I guess I have to do it myself. And with him at my side, John, he's amazing. He's been in healthcare sciences for probably 40 years. He's been in research at very macro levels on Medicare data. But he said to me, I'd like to see it from the inside. I said, Dunny, you're going to, whoa, the day you said that. So every day so often he's yelling across the hall and I have to go calm him down, or I'm yelling about some stupid prior authorization requirement. But otherwise, he's doing amazing things getting out of network benefits coverage, which is the first, I think, in an out of network, out of outpatient setting. I don't think this is done very much in the PANS providers. So we're hoping to set a model that can I not only train people, but also I can train people about how to perhaps do it as a billing practice.
That's amazing. That really is, Peggy. And your PANS Center is in Massachusetts, in
South
Situate,
Boston, Weymouth.
South Boston. Okay.
Weymouth, which is right across the street currently from the South Hospital. This will probably be a temporary home if I get my desire met, which is to continue to hire staff. I've hired my first nurse practitioner a month ago. She's amazing. But I intend to increase it if I can, hopefully including a medical NP to take on more of the Lyme, mold, IVIG ordering question, fill in the blank. And especially as a functional oriented person on that count, along with Tamara, who's my new nurse and very interested in it as well. and also maybe a physician at some day, but this business does not reward us well financially, and that becomes a very difficult proposition.
Yeah.
So, and also I really would like to extend to the whole New England area, because I don't mind if people train here and go elsewhere and open their own practices. I have no proprietary need for anything about this business. This is our retirement plan, so we're giving it a go.
Well, I'm so thrilled you're doing it, and you've always been such a wonderful clinician. I mean, we've known each other probably since at least the early 2000s.
I was trying to remember whenever you joined the Dans, I was there, I think
Yeah.
third year it started, so
My first one was 1998. I was pregnant with my son.
okay, so
And
I think I didn't get there till 1999, 1 year later.
yeah, but I'm so happy to have you in this field. And as you said, it really is a calling and a passion. And I'm just glad you share that and are doing all the work you're doing. So thank
It
you.
really helps me to know other people like you are out there, since this is a very isolating, lonely position to be in a lot of times when you ask about challenges of this job. But it's really good to know, even if we don't talk, that there are others I can reach out to and
Yeah.
connect to. And you've
Yeah.
been great about that.
Absolutely. No, we need to stick together, and the community is important. That's why I started my membership program. Just,
Right.
We meet every month just to talk and know that there are other like-minded people out there, and also, for the families. And, I do a lot in functional medicine, but you and I both know that often these children do need medications, antibiotics, antifungals, but also psychiatric medications. How does prescribing medications for the psychiatric symptoms of PANS differ from treating other mental health disorders?
Well, I'm going to first start talking about what happens in the brain to set the
Yeah.
tone for that. So the first thing is, we all know that PANS creates psychiatric symptoms and behaviors secondary to the inflammation, both in the body and in the brain. But like gut GI, for example, is also a big issue. And so what happens in inflammation is something called cytokines, which are there to help protect and to damage the brain and the other parts of the immune system, are activated with inflammation. But excess cytokine, which really does reflect a lot of PANS people, where there might not just be one strep throat, but then you got strep 3 times in a row, and then you got mycoplasma or COVID added in, or then you have a food allergy or an asthma problem. It's this often a layering of insults to the immune system. And it starts to change the circuits, meaning the tracks and the pathways of dopamine, serotonin, norepinephrine, and other chemicals. But particularly, I'm going to focus on those three, which those are the ones most psychiatric meds are designed to manipulate. So this would be like someone sneaking into the roadway system and changing all the directional signs in a large expanse of major and minor highways in your brain. So now when you treat with medication, it's not clear which pathway and how it's going to work. It's not the same. But before I get just back to that, I want to also mention, very importantly, something I've been always struggling with through the years. And I finally, I think, kind of better understanding of this. And believe me, it's not because I haven't tried, but I probably didn't know the language to query the data really well. But the basal ganglia, which we talk about a lot, Nancy's written a wonderful book about basal ganglia encephalitis, behind her on the shelf, I think, when I'm looking at her, produces changes, particularly in this midbrain area. So if I took a pencil and poked it through my ears and through the nose bridge, I would hit the basal ganglia, kind of frontal midbrain. And it is like grand central for all the dopamine tracks, which control multiple functions, which I'm going to review, about how come your symptoms show up. So first of all, dopamine is the center, and there's a large section in the basal ganglia called the striatum area that is very heavily dopaminergic. And it's the area where it promotes rewards, pleasure, all motor movements, and social interaction. So when this is upset and agitated, or the wrong pathway is running, you are now losing ability to have fun. You don't have as much pleasure. You see a lot of these kids drop their sports, partly because they can't do it, but partly because they just don't have any energy or enthusiasm anymore. Yeah. They stop violin, they stop piano, they stop seeing their friends. So they're left with numb and flatness, reducing motivation. And then they have motor tics and disrupted circuits from those in the same region. They have tics, vocal, motor, and they have stuttering, which I don't see very often, but when I see it, it's very distinct, that there's a dopaminergic disconnect and pathway that's not working right. The second thing is, Dopamine, this one I didn't know. I knew it was always there. We always talk about it, but I didn't understand it again. Decreased and confused dopamine increases sensitivity to aversive stimuli. So aversive stimuli, lights, smells, sounds, people chewing is a big one, right? I had one of those people in my office today that they can't stand, only mom's chewing, not everybody else in the family.
I hear you.
Yeah, lights, textures, the clothing. Sometimes they can't even get dressed. They often drop out of soccer or ballet because they can't put the tights or the socks on anymore, right?
Yeah.
So this is also due to this dopamine change. And a couple more is the activity that this also activates anxiety, fear, alarm bells going off. So you're in this hypervigilant state in the amygdala, which is a tiny little level below the basal ganglia, size of an almond amygdala. And this now becomes a fight, flight, or freeze patterns that people exhibit. So let me give an example of flight. They run away, they try to jump out of moving cars. We know those stories. Freezing, not talking, unable to respond, curled up in a ball, whimpering on the floor, or fighting, oppositional, aggressive, loud, just out of their mind. I one time had a family tell me that their 5-year-old was on the mother in the kitchen beating her up. Now you wonder, how can that happen? When you have adrenaline background, you are strong and you were able to beat up a lot of people. And she was just horrified, but also knew she couldn't fight back. The last piece on this is the damage to the hippocampus, which is the seat of working memory. One of the worst things you hear about is these kids over and over again. I just can't remember. I can't do my work. I can't do my homework. I can't listen in class because I don't remember anything. I don't remember the sentence I just read. I can't go back and keep doing that. So this is all about the circuits that are off. And this is now why medications are going to be very differently administered. So for example, medications like depression, anxiety, you would know it's Prozac or Zoloft. They are supposed to be given for these neurotransmitters, particularly norepinephrine and dopamine, and serotonin with dopamine in the background.
Right.
Normal dosing, when you approach it, backfires most of the time. So the rule is to go low and slow. And so, for example, if I have a 12-year-old who in normal depression or anxiety would tolerate 25 to 50 milligrams, I can start them on 12.5 and I can barely get past 25. But there is a small group who can tolerate typical doses. And in order not to miss that group and misappropriate my attitude to say, no, you shouldn't have that, I do generally try and go up at least one time to make sure they're not in that group.
Interesting.
Other thing is, once they're treated and their inflammation is really in check and I'm doing follow-ups with them, they may still have underlying ADHD or anxiety disorders that now can actually restart a stimulant or now can actually approach a normal dose structure for a typical antidepressant or anti-anxiety medication.
Yeah, absolutely. It was so much to unpack there. I love your analogy with being on the highway and all the signs are messed up. That's so is what you feel when you're with these kids. That's such a great analogy. And also exactly what you're saying, that many of these children do better on very low dose and titrating up slowly, but there are some that need higher doses.
And I know you and I have been told, and I even try it sometimes, they've been on that Prozac for a really long time. I don't think it's doing anything. And I go, well, before you just take it off, let's just go half dose, which may be a really tiny dose, or just do it in isolation of any other change you make. And then we have to watch and wait, because it surprises me how much the little dose of Zoloft is doing for their anxiety that I never knew. They often came to me on that dose. So I've never seen them without it. But I also, when you're first treating people, you don't count on that being the major player.
Right.
So you might put it in place, but it's not going to be a major player in the full treatment.
Right. And absolutely. Often I'm telling parents to shave off part of it or compound it. This is where I will compound it and just take it down by literally drops. And
I'm
it's amazing.
Really picky about, like, liquid Prozac tastes pretty bad, so I don't use it much if I think I'm going liquid. But Zoloft is a wonderful one. Lexapro might be in the background. Zoloft, though, just as an interesting point, genetically is not impaired by what you and I know as 2D6 enzymes, which can matter a lot as to how that Prozac or, let's say, Lexapro are being digested in the liver and how it's spread in the blood. And just statistically, you have a better shot at Zoloft than you do of the other ones.
Yeah, I agree. I agree. And
But I
certainly
just
that's
heard
what we
some
see
new
clinically.
publication that just came out today from Salk Institute that was sent to me by a parent who said, which says, gee, in mouse, Prozac is an antiseptic and antisepsis and
Oh,
anti-inflammatory. Who knew?
wow. Who
But
knew?
it probably has to do with all of these meds that have never been tested. And that may
Yeah.
be why their depression is getting better when they're taking these meds, right?
Right. Because you and I both agree that inflammation and immune support, in the gut, in the body, in the brain is very important in PANS PANDAS, certainly, but in all of mental health, in all
Right.
of health.
Right. And
Yeah.
it's all hopefully coming together with that
Yeah.
kind of publication.
Yeah, we'll fingers crossed.
You're right.
We'll,
Right.
and what about, I mean, you mentioned SSRIs. Do you use any medications more specifically for dopamine?
Yeah, I do actually. I'm often in off-label use at this point now, so I'll mention things that I want to say that stimulants, for example, if you have ADHD, hyperactive, they are a disaster, generally speaking. Even when
Right.
you've been on them, they don't work that way. So as a moderate form, amantadine is one, and it's also
Yeah.
antiviral by chemistry. But you have to be very gingerly with it. People have been too aggressive with it. It normally comes in 100 twice a day, but I order a tablet. Then I cut them down to half of that in the morning and a quarter of that in the morning only, test dosing it. And then only till I get assured that that is not activating and causing insomnia. And that if you read the package insert, it's got all the same side effects as a stimulant.
Yeah.
And then I might gingerly add a tiny dose in the late afternoon. It's not any good if you give it at bedtime, really.
Right.
And then see if it interferes with sleep or activates. But it's
Yeah.
not, it's a hit less than it's a miss. And
Yeah.
with very activated PANS people with bad symptoms. The other one I have really grown to love is memantine. Now,
Yes.
memantine is an Alzheimer's medication. You might say, what the heck? What do people struggle with Alzheimer's? They struggle with short-term working memory. It also turns out new publications are talking about it as an OCD med, same dose. It's
Yeah.
talking about it as an anti-NMDA help, and that I won't go into the boringness of that chemistry, but basically this is part of the excitatory derailed system in the brain with
Yeah.
inflammation called glutamate and glutamate enzymes. NMDA is a glutamate enzyme. So when it's activated in a negative way, memantine is one of the meds that kind of helps calm it down. What is Alzheimer's? They feel it's an illness of inflammation.
Yeah.
There's something going wrong that's layering their brains with tau and tangles, right? So it's pretty much thought there's a lot of inflammation in that process. So to me, always looking for new varieties of how to use meds in that other than normal way.
Right. Right. Absolutely. And memantine is one that has some good studies in autism.
I
as
always
well
hand
as
out the autism,
yeah.
and I've been using it
Yeah.
for years for ADHD. There's a whole
Right.
set of ADHD and a whole set of autism spectrum articles about that. And I've used it for years with spectrum kids because it improves their social reciprocity abilities.
Yeah.
They have a memory now to hear what you just said.
Yeah. And I've seen it. Go ahead.
One mother said to me, well, I know it's working because we stopped having dinosaur discussions all the time at the dinner table.
Yeah. And I've also seen the big one is the social anxiety,
Mm.
and some of that may be the help with working memory and word finding and things like that. But a lot of the kids are more able to engage at not just the dinner table with mom and dad, but more outside the home too.
There's also, I should tell you, I was not going to say this, but there's a brand new antidepressant, well, 2 years old now, that I find I would like to put in everybody's water that I treat. It's called Auvelity. And although all of you are going to go crazy and go ask your provider, you're not going to get them to probably provide it. It's for 18 and above, but with some work I'm doing now to see how far I can go with pushing drug companies to cover it and trying it with a sample ahead of time.
Yeah.
It actually, so in the brain, when you have excess inflammation, your glutamate and NMDA get really excited and run amok.
Right.
The downstream effect of that is to impair what we call BDNF. Took me 4 years to say this word, brain-derived neurotrophic factor. But a simple person said to me, I mean, a brilliant person, Dr. Stephen Stahl said to me, people, it's brain fertilizer. That's all it is. And in fact, it is why ketamine works. It gives a huge dose of BDNF support, but it also has some major side effects. It's not available for most of our patients, and it's too potent. This is like somebody said a ketamine light. So I have seen some unbelievable, very rapid responses to positive diminishment of obsessions, of self-harm ideation, of agitation. They're conversational, they're happier, but there are some dissociative episodes that can occur with it. One child had trouble peeing all of a sudden. I still haven't figured that one out, but it's there. And I'm really excited that there's all these other new meds coming on board in psychiatry who's finally recognized we got to go way outside what we call monoamines, that's dopamine, norepinephrine, and serotonin, and find other ways
Yes.
of intervening here.
Yeah, absolutely. And, we both work in this world, but you do a lot more with the psychiatric medications and, with functional medicine, we use a lot of nutraceuticals.
Right.
What should our families, other practitioners know about the interaction of the psychiatric meds and the over-the-counter or other supplements?
Right. Well, the first rule of thumb is don't get too excited. Just go get a supplement because you heard about it and give it to your child without consulting with your provider unless you don't have one. But even if you don't or do have one, you are not sure what you're doing. And in fact, herbs do matter. Herbs do have drug-drug interactions, and you can inadvertently really put things in a tailspin. So for example, curcumin is one we use a lot as anti-inflammatory. It is also a drug that has some interactions, especially with blood thinning. Also, I don't find it right now in literature, but I know when I was studying genetics a lot and Zoloft, when I mentioned earlier, sertraline, it raises in the serum relative to curcumin. So when somebody came to me on both and I was trying to figure out a proper dose, and then it dawned on me that the curcumin was enhancing the levels, I had to take them off of curcumin before I could actually see what the dose was doing for the child before I increased it. So that's an example. Also, I've seen people get really excited about homeopathy, and usually most homeopathy people do carefully warn you about herxing events, how to do one at a time. But again, if you're doing that when I just prescribed Abilify, I don't know what's up or down or sideways. My rule for my patients, which is not always followed, is you must not introduce something until you talk to me, because you do not know what you're doing. But I truly appreciate the enthusiasm. So for example, I'm at a PANS conference in Columbia about 8 years ago, and I'm in a lunchroom area, which was the most happened to be, they just randomly said, go to this room, go to this room. And I happen to be one with parents. I'm standing in line. I hear two things, HF and NAC. The entire time I'm traveling through the parent group, and I think, okay, all right, here we are. And Paul Hardy, our colleague, used to say, Peggy, this is like a whale watch. Everybody runs to that side of the boat and run to this side of the boat, but they might collapse the boat if we're not careful. So there's a drug that I just saw that someone posted. I got sent to me late last week on the most potent antipsychotic out there, not easily to be given, and certainly not in young children, called Clozaril. Now I'm expecting that I'm going to be brought that information sometime in the next month with great enthusiasm about trying this med. Similar things can happen with things. So if you're hearing about NAC a lot, great, but NAC actually disturbs a lot of kids' stomachs. Methylfolate, probably okay, but you got to make your choices about how you're going to spend your money. And there's a lot of methylfolate out there that's useless in terms of mood. It's 1 milligram or a half of a gram. The psychiatric data and research is it's 15 milligrams, and there's very few products that give you that much methylfolate. It is also prescribable, through Leucovorin, we can use it. But again, people are just desperate. They want to help their child. They've heard from another parent, it's great. It may not be great. And back to Sid Baker, who and I know and love, especially you have a great relationship with him. It's an N of one. Your child is the only one that's the science experiments right now, and you have to respect that. So my rule is always, please talk to me and run it by me. Even if that doesn't happen, the rule is never put more than one in place 4 days closer, unless I tell you,
Exactly.
Yeah.
Adding things one at a time.
Add in so many things, then you have some problem and you got to take it off. My other warning for people is supplement fatigue and going on strike. So many years, over the years, when you and I were treating kids in DANs and similar still with autism, any treatment, they have so many supplements. They send me pictures of them aligned across their kitchen counter. And they're just like, oh my God. And they're talking about the money and the cost. And I just had a kid in here last week, and basically the discussion was on strike. They were on strike. Now, if they go on strike from their supplements, it's not as disastrous as if they go on strike from a major antipsychotic that's holding them out of the hospital. Many of these meds, I am very frank about this, are chemical restraints. So your aggressive, self-inducing, abusive child to themselves and others does not end up in the hospital. Because if they start to self-harm or harm you, we do not have a choice, you and I. They have to go to be a safe place. But if you just suddenly make a kid go on strike, you really risk a really bad problem, and including withdrawal from things. You know, like if you've been on Zoloft for a long time, or even an Ativan dose, which you need for anxiety, and you suddenly stop it, you're going to have such bad rebound. It's not.
Oh, absolutely.
So that's probably enough said about that.
Yeah, well, and I think, a couple of things along those lines. In my monthly teaching just last week in our membership program, I provided a big long list that Jill Krista had put together and that I had amended of the interactions between these medications and the herbals, botanicals, supplements. So you have access to that, Peggy. So
I will have to go in and see that. Yeah.
Because there are interactions and they need to be known about. The other one with curcumin and turmeric is it decreases your iron. So if you're taking too much of it, that may be another effect. And I don't like to call them side effects, because all of these are effects of the medication. They may be good, they may be bad, they may be ones we don't anticipate, but
another one, actually, people inadvertently end up with too much vitamin D. They have this supplement with vitamin D, have that calcium with vitamin D, magnesium, vitamin D, and or because they have a 5,000 unit in their house, they're going to give it to their child. Vitamin D is it's a fat soluble vitamin, and you and I know we talk about A and D are toxic if they're absorbed too high in our body, and it's stored in the fat. And the sweet spot is 40 to 60. There's a lot of data in geriatrics that above 80, you might be even risking more fractures in your body, but it's not clear that any more than 60 is helpful. Now, I know there's some practitioners in functional that like to push it towards 80, but I want it to be comfortable. And you have to count it. A lot of people are not counting because it's in these multi-herbal vitamin supplement minerals packages that nobody's counting up the amount that you're taking. Right. So if you have a child you're giving a lot of different supplements to, pull them out and count up how much vitamin D you're giving them.
Right. And also, every supplement is different. I recently had a family where I had said 1 drop of vitamin D is all this child needs, because in that 1 drop were 2,000 units. The father was giving 1 dropper. And the vitamin D level was 235.
Oh, I've never seen one.
I hadn't either. And, so I think as parents and practitioners, one, brand is important. And you said this about methylfolate. I mean, it's not only the dose, but one of the things that I've learned with methylfolate is it matters which side that methyl group is on, and not all methylfolate supplements are made the same. So the brand is important, the dosage is important. And then, the other thing we've seen a lot, I don't know if you've seen this week on social media, is Dr. Fry's interview on folate receptor antibodies and the use of leucovorin and folinic acid for autism.
Oh, I did see it. Was this
PANDAS?
I got it sent to me as if this was new, and I said
exactly.
Actually, Dr. Fry has been talking about this for years.
Exactly. And Dr. Wells and I published an article this summer that we're also seeing it in kids with PANS and PANDAS. Small study, et cetera. But it's not the be all end all. I think in this world, we're looking for that quick fix. Oh, leucovorin, this simple medication can fix my child's issues. Well, if your child has cerebral folate deficiency and it's supervised by a practitioner, absolutely that may help, but it's not going to, cure autism or help every child with PANS, PANDAS. And so we need to look at these things, not in a vacuum, but in the whole picture of everything we're doing.
Right.
Yeah. And that's one of the challenges, I think, and working with families and caregivers and patients, but there are a lot of them. So what are the challenges and the strategies that you use to help the decision making with these patients and parents and caregivers?
Right. Thank you for that question. I pondered that. I mean, I suggested we talk about this because I do feel like some of the masses are forgetting what it's like to be on the ground
Yeah.
and what we are living. And also parents and families, I feel like join us all the time and they should be informed of this as well. So
Yeah.
glad you're asking. So when I opened the doors in June, I had a wait list carried over from a former business. And also then, you know, by the time I opened up intakes in August, I had more than 80 people on that list. And many people who are relatively new, many people who had been treated and wandering and still treating their children for 10, 15 years. And so in order to try and match insurance, I structured the interviews and the whole intake packet for a lot for the parent to do, you know that story,
Yeah.
and filling in lots and lots of forms and also formalized questionnaires so that I'm not being questioned by insurance about the validity of what I'm measuring. And these are very important. So it demonstrates an actual validity of the illness. The second thing is that it takes 4 to 5 intake meetings to do an intake because it's broken into the family history, the medical history, the psychiatric history, all family and child, and then the interview, both medical and psychiatric with the child. And then when I need it, a treatment plan meeting, so all this can be come together with the lab results in hand. So this has come from a lot of years of trial and error about what did and didn't work. The second thing is, I really want to know a lot about your story. You know, you and I know that it's a clinical diagnosis. It's not a lab diagnosis, but in order to get the clinical diagnosis, it takes careful peeling away different layers and asking different questions, and us in our minds trying to make sense of this, right? I sometimes feel like my mind is playing Tetris, trying to fit the block into the right space.
Yes.
And so I had you asked about older kids. I was going to talk about, she's a good example. I had a 24-year-old who came in, was introduced to me by a therapist, begged me to take her, new to her, but realized pretty quickly this was probably Lyme, tic, PANS. And the story was that I got as far back as a normal childhood up to about 6th grade. She told me she was the best athlete in her middle school. She was a really good friend. She had a lot of friends. And then all of a sudden she came into school and was mute, literally could meet selective mutism diagnosis. She just wouldn't talk. And at other times she was super anxious. She started therapy. Now, I read in one of the things she said later on, because I keep going back and reviewing, trying to make sense out of this story, because she's 24. You know, how did we get here? And she had already told me that she had a tick bite in July of 2022, had meningitis from it, and the ER treated her for a month, the doxy, great. And then the entire slide started happening where in her entire college career ceased to a halt, etc. I found out she had a sport she was really good in, which requires pitching a ball a certain way. And I said, how could you not make that team as a freshman in high school? She goes, I don't know, I just couldn't hit that ball anymore like I needed to hit it, or I couldn't, my swing was just off. And I thought, there is the evidence. That is it. In addition to all the urine issues, all the anxiety, the OCD. So by the time she got to me, there was probably not one unticked box. Her diagnosis list is enormous, because by the time I got a hold of her, she was actually extremely compromised in her room, in her home, barely could drive, too phobic, too disabled, couldn't work because her verbal tics were really bad. So she would be making all sorts of inappropriate noises to the rest of the people in her life in a work setting. So she was really just limited extremely. But it was not until I had to just keep probing and pulling the data in that she gave me, but it took some interviewing to kind of collect the rest of the story. So I really do work with a hypothesis. I build a story in my head, and then I order lab work to know and to check and verify, or detour me to a totally different subset of things I need to pay attention to. Like, oh my gosh, she's got 3 Lyme tick-borne illnesses, right? Bartonella, Babesia, and then maybe no mold, or maybe no Bartonella, but she has autoimmune thyroiditis.
Right.
Maybe really great deficiencies in nutrients, but there's usually something else. So this is the problem, because this takes a lot of time. And I always struggle with having enough time, and also because parents need and want, and the person or the patient want action, want some solution, I'm always not ready to give that at that time period. I try and have something concrete to move to after the lab work's done, and certainly a plan in hand. I'm sure you go through this all the time, but it can't all be solved. So that gets me to my another thing as a strategy. More recently, last 5 or 6 years, I've started to say to parents, caregivers, and the patient, especially children, adolescent, right? What are the goals that I've already gotten what the goal of the parent is in the intake packet, but now I say to the child, if you could tell me 3 things you want me to work on, I would really appreciate it, because there's so much stuff here that I want to know. Interestingly, here's a good example. This child had really bad OCD. They really needed to focus on that. The child said, I have these tics and it's really difficult in school to have these tics. I need you to fix that. Now, he was also very, very, suspicious of me and any meds I might offer. So this is very true most of the time, not all the time, but I thought, okay, let's try you on some medication for your tics, because knowing if I can even diminish the amount of tics he is feeling so embarrassed by, it was a grunting or a throat clearing and a really bad facial tic that's immediately noticeable. I knew then he might trust me to try other things that are more taking care of what the parent knows to be very debilitating. The parents, of course, are really desperate to prove to us, because they've run into so many naysayers, that this is real, right? And so, but I don't want them to discuss this in front of the child. As you and I know, I've had pictures and videos, I go, put those away. Because these children internally are very shamed, embarrassed, and lost as to what has happened to them, and they cannot control it. They've often been to psychiatry, which has endlessly told them, as well as their primary care, as well as the GI, that stomach ache they've had for 10 years is in fact just their anxiety. And so just go to treat it with anxiety, despite all the treatment, besides all the therapy. So they're not trusting. Why should they trust me any more than the last person who gave the story, right? So that's what I see is really the challenge. And so the strategy is to join with the families and to join with the child and try and meet them where they're at. I also try and provide the parents some realistic about what this medication or intervention, whichever I'm doing of any type, is. What am I looking for? What are my goals? What are my expectations? My expectation usually with the first dose is, let's see if I get any side effects. Let's see if I can tolerate this medication. Not to mention, you want me to resolve their OCD and their really high aggression. You want to be able to take them to Disney in 3 weeks. But you have to find out if you want to take them to Disney and have a terrible reaction to something, right? So that's a bit of it. The other thing is, I have had to really learn about freeze as part of anxiety. I never used to understand why parents would come in crying and desperate for a medication, or a child or a patient. I give them medication and supplements, not even supplements, and they never try them. They come back in and say, we never did that. And I go, rewind, can you explain for me what it is? I would be dumbstruck. I would literally just not even know what to say. Like, why are you in my office if you're telling me this, right? You're back, and yet you didn't use what I gave you, please. But they couldn't explain it to me. They kind of just look at me like, I don't know either. I don't know. And then I was working with Sheila Gouch a lot lately, one of my colleagues, and I consult her school, and she's the warrior mom of Massachusetts who helped get the IVIG and advisory council passed. Advisory council panel for PANS. And she said, Peggy, it's freeze. It's freeze. They get to the point they just can't move. And I went, this is what it is. And now I see kids doing too, but particularly parents who are administering these meds. They all like beg you for something, and actually medical personnel are some of the worst at this, but they actually don't want to give their kids medications. Nurses and physicians, they actually are more informed, which I think is why they're more hesitant. But freeze factor is a real problem, and I have learned to appreciate it. It tells me a lot about trauma that I'm paying a lot more attention to, etc. And the last thing I want to say about caregivers and how I manage this, because this is very hard work, very complex work. It's very isolating, because almost everybody I'm running into knows either nothing about it or thinks or the pediatricians around me think I'm kind of crazy. I do my notes, so they're kind of getting informed and trained along the way. But I think about this in an old psychiatric concept called holding. Winnicott was a famous psychiatrist in England shortly after the war. And he studied babies and mothers about the concept of nurturing and holding their pain and their misery and their personhood. And over the years, because I've dealt with tremendously ill psychiatric patients in adult units, I used to run a locked intensive care unit, if you can imagine what that would be in an adult world. And also many child psych units I've been involved with. And the issue is witnessing and holding the suffering and pain along with the family, that I'm working and walking with them alongside them. Then I don't feel so alone and isolated. They don't feel so alone and isolated. And by doing this over the years as a provider, and I think this is a necessary element, you have to be able to tolerate a lot of people's pain and a lot of really risky business around suicidal intent. But over the years, many people come back to me and send me messages, or I just run into them at some event and they go, oh, you treated my son, or you answered a phone call for me 15 years ago. I went and got a strep swab and yeah, they had PANDAS, they treated it. I go, I did. But they remember and are grateful. And that's what still nourishes me.
Right. Right. And so much resonates with me of what you've said. I mean, I often say the best instrument in my office is a tissue box. Because the trauma, the disbelief, the actual shame that these patients as well as their families go through is incredible. But also as caregivers, we have to take, and we're caregivers too, we have to take care of ourselves.
Yeah.
We have to make sure that we're setting the boundaries. And I think it's good as an example for the parents too, because the other thing I see is that as the kids are going through this, sometimes as parents, well-meaning and loving, they're feeding the beast of the disease. They're coddling the child to the point where the secondary effects are outweighing the inflammatory, infectious, or other components of this disease. And I think it's so important to support.
Good
But with
sounding thing.
boundaries.
I'm not very good at self-care. I'm working on it. Actually, I did really well to open this practice. Then it kind of went backwards because we're still really in the building process. We're almost to the end of really creating an amazing intake note that mostly will be imported and everything the patient writes will be actually directly imported. The note, I know I used to do this a lot, but in psychiatry, that's really hard to do. In insurance models, you got to have all these rules met in a note, right? But anyway, so yeah, so self-care is hard, but I also found that just telling a mother, and this was a girl with PANS, but this was after she had pretty much recovered, and we were talking about the mom's horror about her bedroom. I looked, and I said, just close the door. She's 17, just close the door. Mom was furious at me because her OCD required that all beds in the house that were made. And I just said, this kid's going off to college in a year and a half. You better let them know what it is to live and figure out how to do things on their own. Or people, when I say they need to be on birth control, or I said, why are you giving the birth control? They're 17 and a half, going to college in August. You said something about giving her the birth control. I said, she's not managing it? Well, no, she might get pregnant. And I said, better to find out now than when they're in college after you've paid for $40,000, $50,000 of tuition, they can manage their birth control. So yeah, I do try, but I think especially in the beginning, especially for an OCD, or especially restrictive eating, when you're going to be in the hospital if you don't feed your child, they do break all boundaries, all training of OCD, unsticking the parent from the child, there's no other choice, I think, in the beginning for some of them.
Right. And I think,
but later on, you got to kind of pull them away. And that's where the therapy for the parent support is really helpful. The training.
So important. And I talk to parents about that all the time, even if the child can't access it at the time, either because they have autism together with their PANDAS, or they're so deep in a flare, or they're a teenager and refusing, or whatever it may be, it can be very helpful for the parents.
Yeah. And if your parents out there and you're like in Massachusetts, if you know good therapists who you have happened to find, because this happens a lot, please let their providers know, because we keep lists of these people.
Absolutely.
They're very valuable to know. Or a pediatrician who's really very helpful. That's another really valuable thing to know, although we try not to publish their names because they would be absolutely overwhelmed. So that happened some time ago, not me, but somebody else would spread the word. And I thought, oh, geez, that person may be out of it right away, because they're in practices. They just can't do their thing unless they're individual practitioners.
Yeah. But I also think something else you mentioned is really important, and that's the detail with you drill down. We're really being detectives. It really takes, and all of these questionnaires, even though the parents may think, oh my God, this is just overwhelming. Well, this disease is overwhelming, and filling out those questionnaires, my parents have found at least that often helps them. Oh my gosh, I didn't realize that was a trigger. Oh, I forgot about that water damage, the month before this happened, or, and then when you were mentioning that kid that got the doxycycline for a decent amount of time, now we both know that most of the tics carry, multiple spirochetes,
She
and,
actually is, and living in a basement that she was living in the basement at that time that had been flooded
yeah,
and still had mold on the walls. And in fact, she has Bartonella, I think, and Lyme, maybe not Lyme, but 2 out of the 3 or 4, I think 2 definite tick-borne illnesses.
yeah. Yeah, so it takes the detective work. And then the last thing is, I often use the analogy with my families of being their Jeep, and I'm going to give you what I think is the best route to go down, but you're still driving the car. And I need you to tell me this works, this doesn't work, but also what else you may be doing. Because when we're not being transparent with each other, that's where things really fall apart.
Right. And therefore, please keep your provider informed. There's poor
Yes.
messaging all the time. And I will say,
Yeah.
great, thank you for telling me, or we're willing to talk about this,
Yeah.
I
Yeah,
want to mention something
exactly.
else because you asked me, why is this diagnosis so hard and so controversial?
Yeah, that was
Just
what I
talk
was just
about
going to ask you again.
somewhat hard. So part of the thing is, for the clinician who's a psychiatric person, there's so much of this presentation that actually does match traditional diagnostic criteria, but with a twist.
Yeah.
So for depression, anxiety especially, eating disorders, it's not body image problems, but now they have a name called arthritis, so they can diagnose you with a restrictive eating disorder without ever bothering to wonder why that would be.
Right.
They have a name for it now, right? So, but the timing and the severity of the symptoms are what really differentiates a traditional anxiety disorder, separation anxiety disorder, even OCD. It's not so fast and furious in most cases. It's not even though it's not an overnight, it often is a period of several months that
Yeah.
things really escalate. And I call this the treatment seeking, and the experience of the family, I call the suitcase effect, which is you're on this trip and you go on collecting more and more and more diagnoses.
Yeah.
On the other hand, parents and kids have come to me and said, well, Peggy, I think you missed a diagnosis. And I go, well, what one is that? It's usually autism. And I go, well, let's try not to put that on the record unless we really have evidence that that's true, because it could be true, especially in a mild case, but especially as a girl, for example. But there's a lot of times I'm seeing neuropsychiatrists diagnose autism in 15-year-old girls who have never had abnormal peer relationships. They were peer leaders in 4th grade. They had no problem communicating. They had no symptoms of what's required by the DSM to be met, of early onset kind of rule bounds and particular interests and things. But this is true, but because they had really high sensory issues, and the mom could fill out one of the forms, as you know them, that she was socially inept and shut down, she met criteria for autism according to that neuropsychiatrist, and now it is in her record for the ever. And I get so upset because you and I know it's great. I mean, there's no problem with having autism, but how you get treated in an emergency room in a doctor's office, if you have that disorder, you are discriminated against. And it's bad enough with everything else you're struggling with to not then have the parent find out, well, they're autistic. Of course, that's why they're doing this.
Right.
Because you and I know that's every excuse. When we started
Right.
out in autism, the parents had diarrhea up the back of the child 5 days a week, and the doctor would say, well, that's because they have autism. Go away, right? Don't worry about it. They have autism.
Yeah. And I say this all the time, but Sid always used to say, Dr. Baker, it's name it, blame it, tame it, medicine. Well, once you have the name autism, everything gets,
Well,
you know,
right. And parents and children and adults do seek out the right diagnosis. That's good. But the desire is that if you know the right diagnosis, there's a right pill.
Yeah.
And that's where things hit the wall most of the time.
Right.
So
Absolutely.
I just want to
Absolutely.
make that point.
Yeah. I get it. I get it. And how about the controversial part? We know that the AAP just came out with a report that, was limited in the amount of research that it was showing. And we know that there are a lot of practitioners that either since that or long before that don't believe in PANS-PANDAS. How do you address that? What do you think is behind that? What are your thoughts?
Well, I know what's behind it is if you ask people when they train, what did they learn about PANS-PANDAS? It's usually they might have learned about pandas. It's still stuck back in 1998, Sue Sweeto's
Yeah.
article that really changed in 2012 that no one got the message. Or it's not mentioned at all. My new nurse practitioner just graduated from master's, in Peds Psych, and I don't think it was mentioned in all of her training. But remembering that they have to learn a lot in a short period of time. And I continually, I interact with providers, especially when somebody's hospitalized, who are trainees from major mental health programs, Harvard related, for example. And they keep telling me it's controversial, it's not real. And what happened is, little be known but Dr. Dan Geller taught me this one time in a psych farm conference. I sat next to him in the back and I said, why is it that for 10 years or so, there was this long period of time where there was no new publications on PANS-PANDAS, and I kept checking, even when I had internet, right, dial-up. And the reason he said was the head of NIH at that time did not believe in pandas. And then Tom Insel took over, who did believe in pandas, and in fact published one of the beautiful MRI pictures, which I still pull up often, of an enlarged basal ganglia and a normalized after IVIG. And then the publication started again. But what would happen is they would just cough up the old, somebody must have had to write a paper to get tenure or something, or meet their educational requirements, because they would just reformat and restate everything that had been stated the prior 8 years. I have drawers full of these articles. And so nothing advanced for so long. Then the second thing is, only until I think COVID, we finally got a golden ticket to kind of talk more rigorously about viruses and illness and long illness, not short illness. And it's kind of like the groundswell, I think. And one thing that sustains me actually is the work with autism for so long, that you and I were at the beginning of the revolution of people being, remember when we started, people were still being told they were refrigerator mothers.
Oh, yes.
Even further diagnosis. And since then, eating disorder parents have been told that's a controlling mother. And now, with PANS, they're being told it's Munchausen by proxy by the mother, right? And kids are being taken away at times by the courts, still to this day. So I have a very long view. And something Jeff Bland, who in functional medicine, said years ago, he said, from the time it's on the bench in science laboratories, it's 10 years before it even begins to hit clinical practice. So you and I heard about MTHF probably around 2005, maybe. Somewhere in there, he was talking about, he was traveling. I just look back in astonishment, he was going around with his little suitcase and meeting with us in little hotel rooms for evening dinners, right? And he talked about MTHF, and I remember that evening so well. I thought, oh my gosh, this is interesting. 15 years later, the general population might be talking about it, but not even now, but I am really encouraged. I have an adult therapy client who has really bad autoimmune disorder, and her world's expert at Brigham Women's in Boston said to her, one of the first things he said to her is, get off dairy, meat, and gluten.
Wow.
He said, this is lupus. He said, what? He told me I go, I'm just gobsmacked. I said, that's fantastic news. Now, she didn't listen to him for about 8 years. I was like so moved that it finally is upfiltrating and downfiltrating. And so many people have been ill by tics. It's hard to know a family that has not been impacted by it.
Right.
And, and debilitated by it in times. So I'm hopeful, even with the A report, as flawed as it was, it allowed a parent to say, you're wrong if you tell me it doesn't exist. It says it exists right here. Now, the rest of the article was a disaster, which of course, really, my phone and my email were blowing up the day that thing came out with all the upset, despairing people. But if it allows 15 out of 100 more parents not to be denigrated by their pediatrician, that is a blessing. The number of parents who are forced to leave their beloved pediatrician, one of them way back had had a liver transplant at Children's Hospital, one of the first of daughters. That family also had a PANS patient. And when that mother went to that institution to say, my child has PANS, and they said, oh, you're so stupid, you're so wrong, go away. She was devastated. This is the institution that saved her daughter's life. And then she had to make a choice. This is happening to parents all the time.
Yeah.
So I'm
Yeah.
pleased that at least they can say, well, here's the article, Dr. So-and-so.
Yeah. Yeah.
Beyond that, it's a problem, of course, because it's you have to have an active strep. It has to look like strep. It has to smell like strep. It has to swab strep. And by the way, you can only give 10 days of antibiotic, and that's all you can do. Bye-bye.
Yeah.
So we're still stuck in 2012, but it was one little step. And I experienced the same with autism. It was chipping away. It was parents who drove the agenda eventually. You and I did not change. It was parents. And I believe that's still what's happening to this day. Parents who show up the legislator, parents who talk, educate, who support each other, who whisper in people's ears, go get your child checked for strep. Go get your, go check for XYZ. So I am hopeful in the face of despair.
Yeah, no, I hear you. And I think the silver lining approach, the looking for the good in everything, like you said with COVID, recognizing that there are infectious triggered, virally triggered issues, recognizing that just the AAP saying this exists. I think those are really important. And I think we have to remember that the good, every little nugget, and that's true in our kids too. I mean, what we're doing is trying to, people always use the onion analogy and peeling off the layers of the onion. I prefer the gift analogy, that this is a gift wrapped in 9 layers of wrapping paper. And our job is to unwrap each layer, but it's still a gift. And that's the thing that I try to impart to my parents too, that no matter how difficult things are, your child, even this disease, may well be a gift. I mean, I got into PANDAS because of my own family, because of my own child. And, how many kids would we not have helped if we hadn't suffered? And I just think that there are always nuggets of hope that we need to share.
Yeah, it's funny. I've never understood why I was so drawn to this, because I don't have a child with PANDAS. I have one child has some anxiety and stuff, but I then realized years and years later that my mother and dad had a child born with my mother's second child. The child was in labor in the birth canal and not oxygenated, and a covering doctor. This is post World War II. She was having a birth without scopolamine or no anesthesia, which was unheard of. She was having a natural childbirth, one of the first in St. Louis. And the doctor on call ordered the nurse to hold my mother's legs together. And my sister came out with severe cerebral palsy, head to toe. And my parents were fully advised that the treatment of choice was to institutionalize her and put her away and forget about her. And thousands of parents did this, thousands. My parents refused. And my mother loved science. She was a chemistry major as a college person. She worked, she taught for 45 years until she died in 87. But I think somewhere in my neurons early on, the challenge of not status quo was given to me. And my mother was actually quite traditional about defending medicine. But I just think I think that's the connection for me. I never understood it until many years later. But something wrong about what good medicine was telling people. And I did grow in that.
Yeah. And for me, I used to read all those Nancy Drew mysteries as a little kid. And I always loved being a detective. I'm scared to death to walk into a dark building, so I couldn't be an actual detective. But that part of nurturing, doctoring, figuring things out, that drives me also. And
it's really funny because I do really get excited with a new intake. As much as new work, it's like, oh, a new mystery to solve. I really do get excited about it. I go, oh, this is cool, and then I start to see it. I go, there it is, there it is, there it is.
Yeah, exactly. Or when the lab reports come back confirming what you thought.
Yeah, these on follow-ups when they come in, and not only is it, of course, the one thing they're supposed to be here for, but then we hear about all these other things that are happening that are like, oh my goodness, I gotta pull back. Now let's wind back and get a bigger picture on what it is we're actually talking about now.
Yeah.
Not just why that medicine didn't work, except that you were just been in a flare for a month and 4 members of your family had a virus. And that's the other thing that's really struggle, is to get parents to recall that everybody got sick and now they're in a flare. And
Yeah.
I can't tell you the endless times I got to go. They come in, they're majorly depressed. This antidepressant is no longer working. To go, okay, let's talk about who's been sick in the family in the
Yeah.
last 8 weeks. Oh, well, people had COVID over Christmas. It's now January 15th. They had COVID over Christmas. Yeah, all the family members got it. But I go, who was the last member to
That's
get it
it.
and when?
Yeah.
Oh, around January 5th. I go, okay, 2 weeks. It's at least 2 weeks, not if not.
Yeah.
Oh, okay, well, this is flare. And
Yeah.
the most educated people who've actually lectured on PANS in the middle of the trauma of their child going down,
Right.
they cannot recall that most of the time. And I've learned to
Exactly.
just live with it because it's just amazing how that gets wiped out in their
Yeah.
memory.
Yeah. And I think
It's
we have
just
to
a little
remember.
sniff. It's just a little sniffle, Peggy. I go, a little sniffle is not a little thing to your child's antibody system
Exactly.
at all.
Exactly. But it still reminds me that these families, these parents, as intelligent and wonderful as they may be, are struggling and
Oh,
and
totally.
and not of their full ability when it comes to their own child. It's that
Totally.
old shoemaker's kids have no shoes. So
Yeah.
But
And they're
anyway,
done. It was my turn.
Peggy, I could talk to you for
I
another
know.
7
We'll be done
hours,
for
but
now.
we've gone over. And first, I know you're incredibly busy, but how can people find you if they want to?
Panscenter.org, PANSCENTER.org. And there,
Great.
if you want to inquire about admission or is an intake, there is a form there. And I am going to be very honest. I'm not doing an order of what people do because I do have to train people. So different ages matter, different presentations matter. And also I am committed to trying to get new cases who are just diagnosed into the office. They have a lot less history, especially if they're young. And also they're very quickly respond to,
Yeah.
and then I don't have much more to do for them. Many, probably a half come with long histories of treatment already of IVIG, Lyme, mold, or maybe no mold or tick-borne illness because they've only been treated through major medical center people, and they've got a lot of IVIG and a lot of treatment, but they're not better. And and I know that they have to be checked for mold and Lyme and proceed from there. But I'm just a really small resource and I can't do everybody at all the time. So I do kind of try and prioritize. And also for my own training needs, I have to do that.
Yeah, no, I so appreciate your honesty. And Peggy, I so appreciate everything you're doing and being in this world with you. And thank you for all of that.
Thank you for
Any
asking.
last words of wisdom or pearls you want to leave everybody with?
Parent support is out there. You need it whether you have a provider or not. So please get online. There's multiple PANS parents groups. I'm hearing about them all the time. I do not go on them, but yeah, please get yourself support. You're up at 3 a.m. worrying and trying to figure out what the heck's going on in your life. That's a great time to just look, knowing that some of the more severe cases we talked about, but you will find a place and support. Please ask for help. Parents are always saying, I want to give this forward. I always want to help, but they don't know you're out there.
Yeah, absolutely. Well, we know you're out there and we so appreciate it. And thanks for everything, Peggy. Good to see you again.
That's it for today's episode of Demystifying PANS PANDAS. I hope you're walking away with insights, tools, and hope to help you and your child on this journey. If you found today's conversation valuable, be sure to subscribe so you never miss an episode. Share this podcast with anyone who might need it. It could be the lifeline they're searching for. And if you have a moment, leaving a review helps us reach even more families who deserve answers. Also, for more information, training, and community, check out our website, drohara.com, and join our annual membership. And remember, every step forward, no matter how small, brings us closer to healing and understanding. Until next time, be present, be hopeful, and we look forward to seeing you next time on Demystifying PANS PANDAS.